Good morning. Good morning. Now, and welcome to the Great Lakes Health Radio program, the second part of the program here on Power 96.5 FM, WUFO 1080 AM. I'm Francesca Messiah, and as I had mentioned in the earlier part of the program, I have a new title at Kaleida. Before I was manager, workforce development. Now I'm the manager of community health improvement. But still here during the radio show and still with Kaleida. And I have to say, I've been with Kaleida 21 years. It doesn't feel like it. It just feels like a couple of years. But anyway, our topic for today is one that I know you've read about. You've seen it on television and you've seen things on it on social media. And what is that? The flu. The flu in Western New York, respiratory viruses. But the big thing, it's the flu. And how do we prevent it? Many people have been talking about how they've had the flu and it's been worse than COVID. They would never wish it on anybody. And in New York State, we have some of the highest rates this year. And to discuss all of this is our guest for this morning, Dr. John Selleck, who's not a stranger, John Selleck Jr., not a stranger to our program. Good morning, Dr. Selleck. How are you?
I'm very good. Thank you for having me again.
Oh, great. And Dr. Selleck is a hospital epidemiologist, professor of medicine, professor of medicine, Division of Infectious Diseases at UB Jacob School of Medicine. And he's the physician. He's a DO. What does the O stand, Doctor? What does the O stand for again, Dr. Selleck?
That's right. It's Doctor of Osteopathic Medicine.
Doctor of Osteopathic Medicine, and also a Master of Science. So welcome back to the program, Dr. Selleck.
I'm sure there's plenty for us to talk about with flu today.
Yes, yes. But I'm first going to start with, for people who don't know what a epidemiologist is, so my first question, if you could just briefly talk about the role of an epidemiologist in the hospital environment.
Yeah. Epidemiologists are the people who track diseases. Historically was infectious diseases, but epidemiologists are also very involved with things like tracking cancer rates, heart disease, et cetera. For me, as an infectious diseases physician, obviously I'm more interested and more concerned professionally about the infectious diseases, and about somewhere in the vicinity of about 35 years ago, a group of former CDC physicians who were in the Epidemic Intelligence Service realized that you can apply the same principles that we do to look at infectious diseases out in the community. We can apply those same principles of investigation to infections in the hospital. So that's pretty much what I do, is kind of taking a broad look at all of the things that we see with our patients who come to Kaleida facilities. And obviously, there's not a wall there that you're either in the community or in the hospital. It moves across the spectrum of where patients and our community members might be. So I'm never at a loss for things to do, is what it comes down to.
And the hospital is a community, like you said. The community is a hospital. Hospital is a community, so we work hand in hand. Before we talk specifically about the flu, and there are people out there who don't believe in vaccines, but why were vaccines invented? And how many years have vaccines been proven to be effective?
Yeah, I think there's always been interest, especially in the many decades and centuries prior to the advent of antibiotics, things that we could do to prevent people from having horrendous things. Certainly the one that we know about in terms of the longest ago, and actually where the word vaccine comes from, is vaccinia, which was the original vaccine to prevent smallpox, was when it was recognized uh, that the milkmaids who would get these cowpox lesions on their hands would never get smallpox. So there's a cross reaction there between the cowpox virus and the smallpox virus. So that was when hundreds of years ago we started the process of vaccination. Now, many of your listeners are probably not old enough to have the scar on their left arm like I do, which was a vaccination that we received to prevent smallpox. And then as we move forward into the 20th century, by the early part of the 20th century, we saw the development of a vaccine against yellow fever, which we fortunately don't have in the United States. And then more recently, the many vaccines that we know about, excuse me, mumps, measles, rubella, whooping cough, diphtheria. All of these were diseases that were very widespread in the population, and the advent of effective vaccines has prevented them, which is why most people don't know anyone who has had whooping cough or diphtheria or polio, because we have these very good vaccines. All of these are very safe. They're extensively tested. And I know that especially on social media, there's, just a constant stream of misinformation and disinformation about side effects of these vaccines. But they're all very safe. And I can tell you from personal experience, since many of these vaccines didn't exist when I was a kid, I had the ability to compare my experience having had measles and how sick I was with that to that of my children who were vaccinated and never had to go through that. So these are very safe, very effective, and I hope everyone filters out all of the again, the misinformation and disinformation that's so prevalent now on social media and even mainstream media, and make sure that you're up to speed with all of your vaccines.
Yeah, thank you. And something that you said that I pulled from what you just said, all these vaccines are safe and they've been tested. So I just want to make sure that the listeners heard that, as we continue our conversation. Um, the flu, I know the flu has a respiratory component with it, and there are other like COVID may have are all respiratory diseases such as flu the same? Will you feel if someone all of a sudden has difficulty breathing and is that a sign? I guess I should say, what are some of the signs of the flu?
Yeah. Well, I think when you look at, we think most about flu and COVID because that's what's most recent in our memory. But there are many other respiratory viruses as well. They're different viruses. They all have somewhat different uh, some of the nuances of what they do. But basically, what we see with most of them is some level of respiratory symptoms. Often starts out with cough, sore throat. Excuse me. Often there are systemic symptoms that go with it: fever, the shaking chills, the muscle aches. Flu tends to be more severe than people give it credit for. And certainly we saw a lot of severe COVID, and that was largely because humans had never been infected with that virus before. But now that all of us have either had COVID, had vaccines, or both, COVID has not been quite the disaster that it was in 2020 and 2021. But flu is always severe, and flu has this ability to keep changing its stripes. We always say that zebras can't change their stripes. Well, the flu can. And that's why some years we have much more severe flu, both the disease and the number of infections. And it turns out that that's exactly what happened this year, that the, flu in the process of going through its genetic changes has kind of outrun the natural immunity that people may have built up to flu before. So we're seeing a lot of cases in New York and Western New York, but it's the health department report from last week, which always lags by a week. And tomorrow we'll get a new report, and we'll see what that looks like. But the total number of cases being reported was actually down a little bit for New York as a whole and for Western New York. So, and we're starting to see in other states further west of us, further west of the Great Lakes region, their flu activity is starting to pick up. So by the time the season is over, pretty much the whole country is going to be, pretty well beaten up by the flu at one point or another.
Yeah, because before this call, I was just speaking with a friend in Cleveland, and she was just saying how the cases in Cleveland are skyrocketing. But back to New York State. So what made it such that the flu was all over the news in New York State? What was that scenario? Why was that? What happened?
Yeah, it's because there are so many cases. Doctors' offices are overwhelmed. The hospitals and ERs are overwhelmed. We see in our own Kaleida facilities, especially downtown at BGH and out at Suburban, that just huge numbers of people coming into the emergency department. Some of them are sick enough that they need to be admitted. And there's a big backup actually getting people into hospital beds because there are so many cases. So we're all hopeful that the number of cases is going to start going down a little bit to give us a chance to, try to catch our breaths a little bit and, get back to a more normal flow of patients.
And has this been for in New York State? Is it for children, adults, or both?
Both. Flu tends to really move through kids very rapidly, and especially now we're back into the first week of the spring semester of kids in school. We're certainly going to see more cases in kids, and again, it affects all ages. It tends to be worse in the very young. Very small children who have not yet built up immunity to influenza, and people who are older, people who have suppressed immune systems, who have a harder time with the virus.
Hmm. Um, so if someone is one of our listeners, let's say they're living in a multi-generational household where they have children or grandchildren age two going to daycare, and then they have someone else going to work or going to college. How can that household be preventative against the flu?
Yeah, the multi-generation households and multi-generation events, because we are just coming off of, Thanksgiving, Hanukkah, Christmas, New Year's, all of the holidays where people get together. And again, you often have three and sometimes four generations of people all together, and it becomes quite a challenge to protect everyone in the house. You don't really want to send people to their room is essentially what it comes
Right,
down
right.
to. So ideally that's, everybody would live in their own room and that would be it. But,
Right. People
that's a
put the
little
plate
bit,
outside the door.
yeah. Yeah, it's a little bit problematic when you get to, meals and using the bathroom and all that kind of stuff. So I think that, the best things that you can do, number one, getting a flu shot, the vaccine. It's very safe. And this year, even with this mutation, there is a level of protection that comes with it, especially against very severe influenza. So it's not just grandma that we want to get the flu shot, but we want everybody else in the family to get the flu shot so that they don't get sick and then give it to grandma. So everybody getting a flu shot, everybody doing good hand hygiene. If you are sick, wearing a mask and staying in your own room as much as possible until you feel better. All of these are things that can help prevent the most susceptible people, which again is going to be grandma and the very young kids that may be in the family. You have a relatively newborn child or 1 or 2 year old child. Again, those extremes of age are the groups of people who are going to have the hardest time if they get the flu.
And not that it's ever happened, but can the flu kill you?
Oh, absolutely. The flu can the flu can kill you directly, but one of the things that we've known now for about at least going back to the 1990s is that people who have flu have other bad things happen, like having heart attacks, having strokes. If somebody has a congestive heart failure or chronic lung disease, they get the flu, and it may make their heart failure much worse. It may make their lung function much worse. So the flu can, it has a lot of tricks up its sleeve. Again, it can, directly damage your lungs very severely, but can
Hmm.
also cause these other bad things to happen as well.
Hmm. So what if someone is already a cigarette smoker?
I beg your pardon?
So if someone is a cigarette smoker already doing a lot of coughing, and then they
Yeah.
get and then they get the flu, so it could be
Yeah,
life threatening.
yeah, absolutely. That could definitely get them to the hospital and be severely ill. One of the many reasons to stop smoking.
Yeah. No, I would think that would be good. Um,
Yeah.
so along those lines, at what point, and you said the hospital rooms are filled at both our adult hospitals and oh, and for our listeners who didn't know that Oshai Hospital, Children's Hospital is now called Golisano Hospital, Children's Hospital. So so you're saying the rooms at Golisano Children's Hospital are filled, the rooms at our adult hospitals are filled, our physician offices are filled. At what point do you know, should one consider one of our listeners seeking medical attention? At what point do you just say it'll go away, or
Yeah.
do I need to seek medical
Yeah.
attention?
Yeah, it's kind of an individual decision, and it's uh, really depends a lot on who the patient is and what their overall health is. So if you're, if you're a teenager or a young adult and you have a modest fever and some cough, but otherwise you're doing well. There's no real reason to go to your doctor's office or the emergency department just to have someone tell you have the flu. But if you are older, if you have, again, significant underlying diseases, chronic lung disease, heart failure, you're a transplant patient or a cancer patient, unless it's very mild, you should at least touch base with your personal physician and, make some decision about whether or not you should seek a higher level of care. And certainly, if you get very short of breath, very high fever, you become disoriented, all of those things would be reasons to get yourself to urgent medical care. The more severe you are, the more you need to go to the hospital. If it's something that's not too bad, again, making contact with your family doctor or going to an urgent care is going to be better than sitting in the waiting room at the hospital for hours.
Hmm. Yeah. You know, a friend of mine recently had the rhinovirus. Is that what it's called? Another one of
Yeah,
those.
yeah,
And I remember it sounded like the flu. What would be the difference? She's in a school, and I
yeah.
don't know if rhinovirus is more prevalent in school versus a flu.
Yeah. Yeah, rhinovirus is the rhino from the nose. The rhinovirus is the commonest cause of the cold. The common cold is mostly rhinovirus. There are many other viruses that do it as well, but historically it was rhinovirus. But one of the things that we have found now that we have much better testing for these viruses is that there's a lot more rhinovirus in sick people than we had ever expected before. So what you find is that even young, healthy people with asthma, rhinovirus can cause them to have severe asthma attacks. People, again, with chronic lung disease, people with other forms of either diseases or treatments that suppress their immune systems, that rhinovirus can be a very significant cause of these infections. And again, it's a little bit harder, especially for physicians in my age group, excuse me, who are not infectious disease doctors. They say, oh, come on, it's just rhinovirus. What are you worried about? Well, what we know now is that rhinoviruses do cause these more severe respiratory infections, especially in people who are more susceptible. Again, asthma, chronic lung disease, heart disease, transplants, cancer, etc.
I haven't had the flu in so long, and we're talking medicine. So with the flu, can you have like diarrhea and vomiting at the same time?
Yeah, some people will get some GI symptoms with the flu. If you have severe diarrhea and persistent vomiting, then it's much more likely that it's something like norovirus than the flu. Different, it'd be unfortunate that you would get those, both of those at the same time. But we do actually see that again, getting back to this idea of multi-generation households and, these different events around holidays. Where again, grandma wants to play with the kids go to school, or worse, they go to daycare, and they come home with flu and with norovirus, and then all of a sudden everybody in the house or everybody in the family is sick with one or both of them.
Hmm. Hmm. Yeah, I knew. I was around a little person recently who returned from a daycare, and I felt like saying to the adults, like, can we just like, and not to say put her in, can we just like make sure she has all the germs off of her before I give her a hug? Because I know I hear the stories about daycare centers, but I was only joking, and I never said
Yeah,
anything. But I
yeah,
can only imagine the kind of germs just watching the little kids, they don't, they're just innocent, they don't
yeah,
they don't
yeah.
know. um
Okay.
so we have about 4 minutes left. So prevention, you've talked about it a little bit, but let's just focus the end of the program here on prevention of cold, of flu, of RSV, of all these different respiratory disease. As an epidemiologist, what do you say?
Yeah. Well, I think the two big ones that we're seeing right now in adults are obviously flu and COVID. We have very good vaccines against both of those, and I would encourage anyone who has not had those vaccines to go out and get them. You can get them both at the same time, and again, they're very effective, very safe. You may get a little sore arm with it, but it's far better than getting flu or getting COVID. RSV right now we're not seeing quite as much RSV in the adult population, but as the flu simmers down, I would not be surprised if we start seeing more RSV in the adult population, and certainly RSV is always an issue in the pediatric and the younger population. So as far as RSV, we encourage that vaccine in adults, primarily for older people. So if you're older than 75, or if you're older than maybe 50 or 60, but you have heart disease or chronic lung disease, then you should be thinking about getting the RSV vaccine as well.
Mhm. Okay. Well, Dr. Selleck, I want to thank you for being our guest. And Dr. Selleck, Dr. John A. Selleck Jr. is a hospitalist and a hospital epidemiologist, not a hospitalist, a hospital epidemiologist here at Kaleida Health, professor of medicine, disease and infectious diseases at the UB School of Medicine. And Dr. Selleck, thank you so much for letting me call on you and sharing your knowledge with our listeners when it comes to diseases. And they're not just diseases in the hospital, they're diseases that impact the health of our community. And I know you'll be back because as an epidemiologist, I know that you see all kinds of things before we even hear about them. So I want to thank you for being our guest.
That's great. Anytime, I'm always happy to provide the education. So you're absolutely right. I'm sure we're going to be talking again, probably at the beginning of the next flu season next fall.
Right,
Okay.
right, exactly. And
Right.
and I also want to thank Joe, our video photographer, for Joe Lepsch, for making this conversation possible. Thank you. And thank you. And in 2 weeks you'll hear from my in 1 week you'll hear from my host from Erie ECMC, and that's Cindy Bass. And until then, stay healthy, practice hand hygiene. You may want to wear your mask again to prevent the flu, COVID, and all these other respiratory diseases that are with us this winter. So thank you, everybody. And now on to part two. Welcome to the second half of the Great Lakes Health Radio program here on Power 96.5 FM, WUFO AM, 1080 AM, or you might be listening through one of the streaming services. So good morning to everyone. I like to talk about a few topics because they affect our life. What is that? What we eat and our heart. If your heart isn't beating, you're just not here. So today's topic is called How Healthy is Your Heart? Well, we're going to be talking about your heart of your loved ones. We're also going to be talking about heart disease. And we also have on our program a survivor of I'll let him tell you the correct medical term, but it was a heart attack. It was a bad one, and he survived. So our guests for today are Dr. Fred Archer. Good morning, Dr. Archer. How are you?
I am fantastic, Fran. Always good to hear you.
Oh, great. And Dr. Archer is a clinical assistant professor of pediatrics in the Division of General Pediatrics with the Jacobs School of Medicine and Biomedical Sciences. Also attending physician at Niagara Pediatrics and Broadway Pediatrics, and also an associate dean of admissions at Jacobs School of Medicine and Biomedical Sciences. Do you sleep, Dr. Archer?
Only occasionally, like I just had a nap like 5 seconds ago.
Okay, thank you. And our second guest, again, not a stranger to the show, and that is Dr. George Matthews. Good morning, Dr. Matthews. How are you?
I am great, Miss Messiah. It's always a pleasure working with you and Dr. Archer.
Thank you. And Dr. Matthews is the Chief of Service here at Buffalo General Medical Center, Kaleida Health, Department of Medicine. And the reason for today's show, I know I tried to do this before, but the reason for today's show, not only are both of these physicians of color, because they are, one, Dr. Matthews is a cardiologist, as I mentioned. Oh, I didn't say he was he is a cardiologist. And also, Dr. Archer is a pediatrician. What is the connection, you might say? The connection is that Dr. Matthews who's a cardiologist, and Dr. Archer is the one who had the near fatal heart attack. So I said, let me bring the two together and let's have someone who actually had a heart attack with a conversation with the cardiologist. So starting out, Dr. Matthews, what is heart disease? And if you have heart disease, what's the likelihood of having a heart attack?
Well, thank you, Ms. Messiah. Let me begin by saying heart disease or cardiovascular disease, which is the broad term, describes the process where there is an issue which affects either the arteries of the heart, the muscle of the heart, or the lining of the heart, or the valves of the heart. Now, to put it in perspective, the heart's main job is to pump blood carrying nutrients and oxygen to the various organs. When the heart cannot pump sufficient blood, then we may feel fatigued, we may feel weak, we may have chest discomfort, we may have a whole host of issues. The important aspect is to remember that we're trying to maintain the ability of the heart to pump blood sufficient to satisfy the needs of the body. The most common form of heart disease, the one that we often describe as causing heart attack, is one in which we reference coronary artery disease, or disease involving the arteries of the heart itself. When these arteries develop a blockage or narrowing as a consequence of the buildup of fat or cholesterol within the blood vessel, then that can lead to chest discomfort, shortness of breath, chest pain that may eventually result in a heart attack or myocardial infarction. The important aspect is that we want to prevent that from occurring. Now, one of the things that we want to consider is the likelihood of having this develop, the likelihood of having heart disease. If an individual has buildup of that plaque within the blood vessels of the heart, then there is an increased likelihood of heart attack or damage to the heart muscle. Other issues which may affect the heart as a consequence of valve problems, or issues which may be a consequence of abnormal heart rhythms, also can provide for heart attacks. But the most common manifestation is that of the buildup of atherosclerosis, or hardening of the arteries, you may have heard, and that buildup may compromise the pumping capacity of the heart and eventually potentially result in heart attack damage.
Wow. And none of this happens overnight, right?
Not at all. Interestingly enough, this occurs after we're born and we start eating foods, we start living a lifestyle. The things that may contribute to the development of heart disease: high blood pressure, cholesterol buildup, as I've referenced earlier, tobacco use, diabetes, an unhealthy diet, one that's high in fat, may also contribute. Physical inactivity, and we often think that we are getting enough activity just doing our daily activities around the house. Not enough. We need to have more. The American Heart Association suggests approximately 150 minutes of exercise per week. Again, one of the things that we don't like to think about is obesity, or the buildup of or excessive weight, which may be a manifestation of some of the other aspects that I've discussed, specifically dietary imprudence, eating those foods which may be not the most healthy, foods high in salt, sugar, um, fat, and things that we don't think about, alcohol use, which may raise the blood pressure and contribute to the development of heart disease. Lastly, or sleep disorders, and most importantly, or equally importantly, family history, because we don't think about it, but all too often, having family members who have had heart disease, first degree family members, meaning father, mother, brother, or sister, may confer an increased risk of heart disease.
Yes, and yeah, no, that's so true. I remember years ago having a friend and who was telling me how heart disease had killed all the men. Many of the men in his family had died from heart disease, from a heart attack. And I don't know, he was almost 50. And I said thinking to myself, what does that have to do with him? Because he seemed perfectly healthy. Didn't know, although I didn't know they had diabetes and high blood pressure. I didn't know that. And don't you know, within a couple of days, I had a massive coronary and died.
Very,
So, yeah.
yeah, no, that's very important. The way I often look at it is if you have a first degree relative, parent, brother, or sister, and if it was a man and they had that heart attack before the age of 55, then you are at risk. If it's a if the mother or the sister had her heart illness before the age of 65, then your risk is higher as well. Now, family history matters because genetics can influence how our body handles cholesterol and fats, what our blood pressure is, and the potential likelihood of developing diabetes. So we have to take all of these into account and realize that many of the risk factors we can address, but genetics we can't. So we have to do everything we can to affect those risk factors that we can have some ability to modify.
Well, thank you. Thank you, Dr. Matthews. Dr. Archer, and you did have a heart attack, right?
That is correct.
Um, so I know, like, a lot of times I always have to go back to Fred Sanford. I guess it just ages me more and more and more. And when Fred Sanford would grab his heart, he'd say, "Elizabeth, Elizabeth,
This is the big one,
eh,
Elizabeth.
this is the big one." Oh, so you had a heart attack, and did you experience any of the chest pains or any of the symptoms that we see on television? Because sometimes the television appears to be reality. So, did you have anything like that? And was heart disease in your family?
So, in answer to your first question, I did not. We were sitting down, and this is such a Buffalo story. We were watching a Bills game, and I remember the last thing I recall is lift my hands up to cheer as we scored a touchdown, and then I blinked, and the next thing I knew, I was in a hospital bed. So I kind of checked out for a minute there. I do not recall any kind of chest pain, anything like that leading up to it. Now, that morning, we participated in a function where we were doing some stationary bike riding, and I could be in better shape, but I wasn't pushing myself crazy. So I wasn't, I was a little tired, but not, oh my God, I'm fatigued. Oh my God, I can't move anything. And so it definitely kind of came out of the blue from my understanding. But when I was talking to the cardiologist and talking with my family and doing some, discussion afterwards, I knew that my father had had a heart attack when he was in his mid 50s, when I was much younger, close to the age that I am now. His was due to a blockage. He had cholesterol. He had an atherosclerotic plaque. He had to go through a process called angioplasty to get that all cleared out. And so I've always been kind of mindful of my cholesterol. But my heart attack was actually due to what's called an arrhythmia, an irregular beating of the heart. People have heard of AFib. That's kind of in that kind of category. Mine was due to something called ventricular tachycardia, where it just started beating ridiculously fast and out of sync, out of rhythm. And upon discussion with my family, that is something that had been in my family history. but it wasn't, but it was occurred when that person was a child. So it wasn't thought to be something that would occur in the adult population. So that's why when Dr. Matthews said, know that family history, know that family history, know that family history, it is critically important for people to talk about these things. And we know back in the day, folks didn't talk about that. Oh, it's not polite. We don't need to know. People are very secretive. It is crucial for you to know your family history because it can actually save your life and the lives of your children and other members of your family. It's very important. So we did a lot of discussion and found out that these arrhythmias did happen to run in our family. But so and all these different symptoms can present a lot of different ways. That traditional crushing chest pain is one way that heart attacks can present, most definitely. And it is relatively common to present that way. But in other ways, it's just, as Dr. Matthews said, I'm just really feeling, I have no energy. I'm really feeling out of breath. I'm really suddenly feeling, lightheaded. And I just can't really get my thoughts together straight because my heart's not beating properly. It's not getting oxygen through the system to my brain and all of those things. So it was an interesting experience, I'll tell you that.
Oh no, I trust me, I recall. Um, and Dr. Matthews, how common is if someone has the arrhythmia? How common is that for patients? Is it any more common for that type of a heart attack than a heart attack where you suddenly have tightness in the chest?
Well, that's a great question. Let me put it into perspective because um, Dr. Archer eloquently described a manifestation that unfortunately we don't appreciate as often, mostly because people don't survive that event. And so we never are able to get a better understanding. But it is all too common for individuals to experience that abnormal rhythm that Dr. Archer described. And unfortunately, they're feeling fine 1 minute and then they collapse and they've been deemed to have a heart attack and died. And we did not appreciate that they had that particular symptom as a first manifestation. So yes, Francesca, it is more common than we care to admit. And that's all the more reason, as Dr. Archer described, that we've got to have a excellent understanding of what our risk is for heart disease.
Mm-hmm. And that brings me to the next question. Because something you just mentioned, you're talking about survival versus non-survival. I have to say Melissa Archer, because Melissa Archer, Dr. Archer's wife, who is a nurse practitioner, knew about CPR. Dr. Matthews, what is CPR?
Well, that those three letters, cardiopulmonary resuscitation, they entail the manner in which when someone is deemed to be unresponsive and they may have suffered a heart attack, that we can assist in restoring the um, pumping of blood by doing chest compressions. And unfortunately, not enough of us know how to do that and do it appropriately. Dr. Archer was extremely fortunate is in as much as his wife has an excellent understanding and knew how to do it and do it appropriately, sufficiently so that he was able to not only survive, but to receive the subsequent care that is necessary. So when someone collapses, the American Heart Association has a great course that we can all go through to say, how do we get this person or how do we attend to this person in a fashion to maintain their circulation until we have appropriate additional medical resources available, until the ambulance or EMT arrives to assist us. But in Dr. Archer's case, and we cannot say this enough, we all should have a, a spouse
A
or a
friend?
partner such
Somebody.
as his who can provide that care immediately.
Mm-hmm. Yeah, so I'm going to ask Dr. Archer, where does CPR training take place? But if you see someone has collapsed, you know, is it which do you do first, CPR or I hate to say those paddles, the defibrillator, the things you sometimes see on the walls. And for and what exactly, let me ask, what are those things you sometimes see in a building and you place the paddles? I mean, is that just as important as CPR, or do you do the CPR first if you
Well,
see someone?
well,
And what, yeah.
yeah, and that's an excellent question. Um, Again, when someone collapses, the most important thing is to determine if they are breathing, if they have an airway, if they have a circulation, if do they have a pulse. Once we establish that, then we can, or the absence of that, then we can begin CPR. Unfortunately, even though the AEDs, those devices, are available in many public places, to be very frank with you, when someone collapses, they are not available. And Dr. Archer is an excellent example. He collapsed at home, and fortunately, his wife did the right thing in providing CPR. If they had to wait for EMTs or paddles to come, that would have been catastrophic. In most places, there are not those paddles readily available. If someone collapses on the street, an individual who is present can start CPR, ask for other bystanders to call 911, ask for other bystanders to get the AED, which can identify if there is an abnormal rhythm and provide the shock. But the important thing is not to wait to begin the process to establish, is the person breathing? Do they have a circulation? If they don't, then begin CPR and marshal those additional resources to allow the individual to survive.
Thank you. Dr. Archer, CPR training. I know that you were trying to get more people involved with CPR training. Where does it take place? And let's say someone is doing CPR training on one of those, for lack of better words, dummies. Should should you be sweating after? I mean, how do you know you're doing it properly, Dr. Archer?
Those are all great things. One thing I want to add on there to emphasize, to just kind of tangent off what Dr. Matthews said, arrests at home are very dangerous, and only about 1 in 10 do well. And a lot of that is because people do not start CPR soon enough. And more importantly, people see CPR, they watch TV, and
Right.
there's a combination of breathing with the compressions, and the compressions are where you're putting your hands right on the chest and pumping up and down. You are replacing the person's heart in that instance. And that is the important thing. Don't get that process started as soon as possible. So if somebody drops and collapses, you ain't got no heartbeat, boom, you're doing compressions. The joke you hear in CPR training is, if you are not sweating, you haven't done it right. If you haven't broken the chest bone or some ribs, you haven't done it right. And that's where a lot of people really got to get concerned and scared. They don't want to hurt their friend. They don't want to hurt their loved one. They don't want to hurt that relative by, oh, I'm pushing on their chest too hard. Push on their chest hard. Because if they can complain about their ribs being sore afterwards, then they're alive and you did your job right. Okay. And yes, you should be feeling out of breath and sweating after you do that. Because like I said, you're replacing the heart. And the numbers to keep in mind, people want to know, well, how often should you do it? How fast should you do it? 100 beats a minute, 100 beats a minute, 100 beats a minute. And people want to know, well, how do I remember that? There are 3 songs I will give you, depending on the genre of music you like, that will give you 100 beats a minute. Good old-fashioned Staying Alive, which I think is kind of ironic that the song is called Staying Alive, but Staying Alive will get you 100 beats a minute. If you want to be a little bit more fancy, Beyonce, Crazy in Love, that'll get you 100 beats a minute. If you want to get a little bit more modern, Kendrick Lamar, Not Like Us, 100 beats a minute.
So 100 beats a minute, does that mean you can't? Okay, so if you don't have that song,
so when you just go with that beat, dun, 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 dun,
and press as hard as you can.
That beat is 100 times a minute. And so if you're pushing down on the beat with that, you'll be providing 100 beats a minute. And that's what a struggling heart's going to need just to try and make it, And CPR training can be done anywhere, and it can be done in a lot of places with a lot of groups. I myself, do hands-only CPR teaching. I'll go to schools, I'll go to your church, I'll go to your community center. The American Heart Association offers training, and will give a location of where you can do that. The American Red Cross does this type of training. The vast majority, there's organizations through the medical school and through Buffalo General, through Children's Hospital, where people are coming out and will come to your organization and do this type of training for you. And the key thing is, it's not just the CPR I'm really pushing. It's that hands-only CPR, where you're not worrying about getting the breathing in conjunction with that. We're just talking about keeping the heart going as long as you can until additional help arrives, because that can make the difference between A, that person just being here or not, and B, them having some kind of functionality afterwards. That hands-only CPR is no joke. And the fact that, and we also say, anybody can learn that. We teach it to elementary school kids. Now, it might be a little bit harder, for a first grader to do that, but it's better than nothing. But once you get to around 6th, 7th, 7th grade, all of a sudden you can put that weight behind there. You can make a difference. And if you tell a kid, pump on the heart, call 911, that's all you need to get that process started. And that can make the difference. That can make all the difference.
Yeah, because in your case, I think that's what your son did, right?
Yeah,
Called
my
911?
wife started doing CPR. She
Right.
yelled at him to get the phone
Right.
open. He had 911 going.
Right.
And what happened to me is the way the system is supposed to work. My wife
right.
started doing CPR, doing compressions. My son got 911 on the line. 911 responded immediately, because as fate would have it, when the call went out, my neighbors down the street are part of the local fire department. So they mobilized because they saw, oh, I know that address. And they came into our house, and my wife was able to get support immediately. And they were able to call ahead to the hospital. So when I got there, they were prepared to handle what was coming in. And it was pretty bad. You want to talk about those, automated external defibrillators to get your heart going. I got shocked 6 times. My heart was not doing well. Okay. Yeah, that's not normal. That's not normal at all. The fact that I'm sitting here talking to y'all is literally a miracle and a blessing that I thank my wife for and my kids for every day, every single day. And my chest was sore for a month after. Don't tell me no dad jokes. I was messed up.
Oh.
Okay. But I was alive to complain about it. I was alive to feel that. So that's all the difference.
And you're live for the interview. Starting with Dr. Matthews, closing remarks, and then Dr. Archer, closing remarks.
This has been a great discussion, and I appreciate Dr. Archer's comments because he saw it firsthand. Let me just say that there are differences between symptoms in men and women, and just so we appreciate that. Men have commonly experienced chest discomfort when they have a heart attack. Shortness of breath, sweating, lightheadedness, nausea, vomiting, shortness of breath. That's what we see commonly in men and women as well. But women oftentimes may experience more atypical symptoms: shortness of breath, unusual fatigue, nausea, indigestion. They may get a little bit of dizziness. They may get the symptoms that we don't often associate with heart attack, but for all intents and purposes may represent significant heart disease. So it may not sound the typical chest pain or a collapse that Dr. Archer described, but those other symptoms may herald the presence of heart disease. Thank you, Ms. Messiah.
And one more quick question, Dr. Matthews. If someone is experiencing this, tell their primary care doctor, and then they'll give them the name of a cardiologist. How would that work? Absolutely. And we're blessed that if someone is experiencing symptoms that are significant by virtue of either chest discomfort or the like, then call the primary care physician, and the primary care physician will make a determination of whether they should come into their office or go directly to the emergency department or seek urgent medical attention. But the important thing is to get a medical professional to make a evaluation. And that can be in
initially with their primary care physician or in the emergency department.
Thank you. Dr. Archer, minute and a half. What are your final
Minute and a
comments?
half, no pressure. Okay. So first thing is, I will definitely say to everybody, know your family history. And if there is something, talk to your primary care doctor immediately. You don't need to wait for symptoms till you actually get yourself checked out. And if there is a family history, especially not just of that cholesterol buildup in the plaques and the traditional things, but arrhythmias, irregular heartbeats, talk to your physician and they can direct you to the proper place to get screened, to get that EKG going. And so that can happen even in my realm, the pediatric world, because a lot of times kids will have these irregular heartbeats, these irregular rhythms, these valve problems, and that can be picked up earlier, so you can do something about it earlier. So early detection, if you know there's a family history, is always huge. And I can not overemphasize learning hands-only CPR enough. That is something that anybody can learn to do. Somebody drops in the street and you are not just standing there taking a video, you are involved in helping that person. You are involved in that process that can make a difference between that person going home to their family or going to the funeral home. And we would prefer going home to your family. So that's definitely where I would go. Make sure that you know what to do, because if you know something, you're not paralyzed in that instance. You can be effective in that instance. And that is how people survive. Too many people get scared and panic in the moment. And you need to have that kind of mental clarity in that moment to realize, I have the ability to do something. I have the ability to do something. And so if you go through it, talk to other people about your experience. If one other person hears that story and they do something, then that story is worthwhile.
I just have to say, my last comment to both of you. So, okay, I think someone in my family, like directly, has had an irregular heartbeat. Does that mean I should go make an appointment to see a cardiologist to check my heart out?
I wouldn't say no.
I mean, you that's what the beauty of doing the show. Sometimes it makes you realize what is in your family. Oh, okay.
The worst thing that happens is, well, you find out that your heart's fine and everything's great. And the best thing that happens is you find out that there is a problem and you get help early.
Okay. Well, Dr. Matthews and Dr. Archer, I want to thank you for bringing that awareness to me. And I want to thank you for the great information you have shared with our listeners, and hopefully have making a difference in their lives, the lives of our family, and most important, the lives of those in our community. So I want to thank you both for being our guests this morning on the Great Lakes Health Radio program. And I just want to remind our listeners in next week, you'll hear from my esteemed colleague, Cindy Bass from Erie County Medical Center. And God be willing, I'll be back with you in 2 weeks. Bye-bye.